So I'm Nicolas Garnier. I'm the lead of the Screen4Care consortium. I'm also the head of patient advocacy for Pfizer, oncology, and rare disease global product development. I'm a scientist by training. I have a PhD in experimental medicine and then did a postdoc in functional genomics of leukemias at St. Justin Hospital in Canada before joining Pfizer. My dear colleague and co-lead for Screen4Care, Alessandra Ferlini, the scientific coordinator, is an associate professor in medical genetics and head of the medical genetics unit at University of Ferrara in Italy. And I will start by giving just an overview of what is Screen4Care, how it came together. This is a public-private partnership, so it's very important, and I'll be having an opportunity to explain sort of what is the role of industry in this consortium and how this came about, and then Alessandra will dive a little deeper into the science and into what the project will actually deliver. So I'm going to be preaching to the choir, I think, but it's important to remind us what are we trying to address. So we put this a little bit together, a statement of the issue. And actually for Screen4Care, the impulse came from the EU Commission in 2019, who asked the industry, namely EFPIA, I'll get back to that, hey, can you do something for rare disease communities? Can you do something big, impactful, and help rare disease patients who is an underserved community? And so we organized a workshop, I remember in June of 2019 in Brussels, where we invited industry partners, pharmaceutical companies, patient advocacy organizations, and academic experts, scientists, researchers to think about that for a minute, actually for 2 days. And then after 2 days, we came down to, and obviously based on the literature, that the issues that the rare disease communities face can be summarized as lack of diagnosis, lack of R&D and new therapies, and lack of access. And we quickly decided to focus on diagnosis, first of all, because we have to start somewhere, and second of all, because we believe that these issues are actually related. Right now, we are in an ethical framework where it's extremely difficult to screen for diseases that don't have a treatment, and the vast majority of rare diseases don't have a treatment. So therefore, there's no screening, no diagnosis, and therefore there's no data, there's no natural history, there's no understanding really of the disease, and we cannot develop endpoints. So R&D is very difficult. And if there's no R&D, there's no treatment. So access is not even a conversation. And then patients keep experiencing poor outcomes along with their families. So how can we tackle this? Well, so I don't know how many of you are familiar with the IMI framework. It actually just changed name. It's now called IHI, but it doesn't matter. IMI stands for Innovative Medicines Initiative. And it's really a framework for public-private partnership. It is the world's largest public-private partnership, equally supported by the EU Commission and by the pharmaceutical industry through EFPIA, which is the European Federation of Pharmaceutical Industries and Association. And so typically IMI projects, and Screen4Care is no exception to that, bring to the table everybody who has a say in the projects, in the problem that you're trying to tackle. Patient groups, universities, pharma and other industries, small biotech and small companies, and everybody who should be really at the table of conversation from the beginning. There's many projects under the remit of IMI, which is now IHI, but we still use the IMI framework. And so what is the strength of a framework like the IMI mechanism is really creates long-term investment. You'll see in a minute, we'll show exactly the nuts and bolts of the project, but really create a long-term sustainable solution from complex multidimensional challenges. And this is basically what we're talking about here. It allows to align diverse perspective towards a common goal of advancing scientific and medical innovation, both people who have concerns, people who are supporters, and bring everybody from the beginning. So we don't have to do the convincing when the project is over, we do the convincing before the project starts. It allows collaboration and involvement of diverse stakeholders with diverse expertise and different angles, and really expertise also in how to drive a project with a robust framework from a paperwork perspective, legal perspective, IP, ethics, and whatnot, and in a coordinated fashion. Efficiency, because in the context of Screen4Care, it allows data sharing, sample as well, and everything that goes with it. And obviously, none of that could work without trust, which I hope and I'm pretty confident that we're generating within Screen4Care. So the goal of Screen4Care is to accelerate diagnosis for rare disease patients through genetic newborn screening and artificial intelligence. So Screen4Care is broader than newborn sequencing. We also have a phenotypic approach leveraging AI, but obviously the focus of the conversation today is going to revolve around newborn sequencing. We started in October 1st of 2021 officially, but like I said, the impulse really came in 2019, where through AFPIA, we put together the pharmaceutical partners, what's called a topic text. So 10 plus of us, Pfizer, Takeda, Roche, Novartis, Novo Nordisk, Sanofi, ProQR, Lysogene, and PTC Therapeutics, and Illumina. We came together as the private sector and put together the overall high-level objectives and deliverables that the project should have. And then the EU Commission takes this, and when it's approved, reviewed by independent scientific committee, independent ethics committee, then turns it into an RFP, a request for proposals, where academic partners, academic institutions, scientists can really look at the topic text and explain in great detail how they propose to do that within the context of the IMI framework. And then independently of the private partners, it's really IMI and the EU Commission that selects the winning consortium that put together the best proposal to answer the issue that is on the table. And that's how Screen4Care was truly born, because after the robust selection process, the private partners and the public partners meet, and now you have 5 years to do what you said you were going to do. In terms of funding, the private sector puts, on the table in-kind donations, so time, intellectual contribution, but also data, sometimes sample, although it's not the case for Screen4Care, but sample can be used as well. And obviously financial contribution. And then the commission matches that in private investment, and that forms in a sort of more or less 50-50 way, the total budget for Screen4Care, which is 25 million euros. We have actually 36 partners because we just added a new partner, over 14 countries across EU. But obviously, we're just extending the open end everybody, because we don't want to reinvent the wheel, and we want to collaborate, and that's why we're here. I'll just say a few words because again, Screen4Care is a big project with many partners, 35 partners, hundreds of people working every day on Screen4Care. And this is supported by taxpayer money. So obviously everything needs to be really tight and transparent. So we have many boards and mechanisms to make sure that the discussions are happening. We're very happy to have an ethics, legal, and safety team dedicated to those issues. We have also a communication and dissemination working group and innovation board that's going to look more at the sustainability. What's going to happen to Screen4Care and its output beyond 5 years, which is still obviously in the making. We have a scientific advisory board, of course, with experts from across the world to also help us understand what we need to do and how. A multi-stakeholder engagement board, a bit more general, but very typical of IMI projects. We actually have an EMA, European Medicines Agency, and so the European equivalent of the FDA, sitting on our multi-stakeholder engagement board, again, to raise concerns or give advice or exactly understand what's going on. And then we have different ways of working together across so many partners. You will hear sometimes the word work package. That just means a discrete unit of work within the broader consortium that allows people to work in smaller teams and work in a more agile fashion and faster ways. And then obviously, Screen4Care would not be Screen4Care if the voice of the patient wasn't at the heart of the project. They were there from day one, June 2019, Brussels, patient advocacy organizations giving their feedback. EURORDIS, the European equivalent of NORD, International Patient Advocacy Organizations for Rare Disease Patients, is a member of Screen4Care, the chair, our patient advisory board. But as you'll see in a minute, we made sure that we don't just have a patient advisory board, because that's kind of easy to do. We actually embed across all of the work streams, all of the work package, really making sure that we constantly have our ear to what patients, their needs and preferences. So like I was just saying, right, we really count on our patient advisory board to provide us with strategic recommendations, really open door policy, open book. They can look at everything and anything we produce and plan to do, and then just tell us whether we are going in the right direction or whether we should adjust a little bit. Like I said, we don't want to reinvent the wheel, so we started by doing a strategic landscape analysis to try and identify all of the projects out there, kind of in the spirit of this conference, actually, to make sure that, again, we use our resources efficiently. We look for synergies, collaborations, because I think that the last thing that this field needs is competition. So we really need to all collaborate, work together as much as we can. So I think, we're a bit short on time. I think this is my last slide. So I will pass the baton to Alessandra, who's going to speak in more details.
So thank you, Nicola. Probably you have already, well understood why we are co-presenting this project, because we are co-leaders, and this is a tremendous added value for this, especially for this issue, so for the newborn screening and the ecosystem, rare disease early diagnosis. So the project has just started, so in 1 year ago. We spent this year in a lot of preparatory activities, huge effort, especially in all ethical issues, project design, and also genetic, tools design. In order to get to meet our main 3 pillars of the Screen4Care, which are the first one is federated building up of the rare disease newborn screening ecosystem. This is a knowledge-based pillar. So in this pillar, we will scan all knowledges existing related to rare disease and newborn screening, genetic newborn screening, in order to build up a sort of encyclopedia on all data which are available in literature, because as Nicolas said, we don't want to invent nothing, we don't want to duplicate efforts, but this we need, of course, to know what is already there. And then second pillar, second aim, of course, is the newborn screening. So the idea is to pilot a sustainable genetic newborn screening. Sustainable is a key word of the Screen4Care, because Screen4Care is a research project, just to have this statement from the beginning. So it's not a public health program. It's a research project where we should try to, following the experimental path and the experimental method, to design, co-create, explore, demonstrate which are the best approaches in order to get genetic newborn screening offered to rare disease patients, but also to achieve an early genetic diagnosis for those patients. So it's a dual aims. And to do that, indeed, we will use many digital tools, so digital technologies. European projects are, already, robustly and, organized in the structure of work packages. So these are the work packages of the Screen4Care. We have 6 work packages. Each of them is devoted to a specific aim. Of course, we have work package 1 for all the ethical, legal issues, societally aspects of rare diseases. Work package 2 is that the ecosystem, so connecting and integrating by using interoperable systems, all data existing on rare diseases and genetic newborn screening. Work package 3, we go there in a while, is the newborn screening pilot testing, and based on, you will see different approaches. And then we have the two digital packs, so work packages, 4 and 5, where we will develop novel digital tools that we will be, used both for the following up of the tested babies in the pilot newborn screening study, and also to cycle patients during their whole life using the symptom checker in order to better help patients to address, not to get the diagnosis, but to address which is the right path they have to follow in order to get the final diagnosis. Therefore, referring centers, referring ACP, so healthcare providers. So this is a very large, and comprehensive way to meet the patient's need, not only at the birth, but also long life. And then work package 6 is the management, dissemination, and coordination, working package. The approaches are clear now for you. So we have genetic newborn screening and the digital solutions. And we have a lot of transversal activities in order to integrate our digital approaches to newborn screening. How? You see here the work package 3, which is the core of the newborn screening, and is also, orchestrated, organized in different tasks. So we have preference studies. We have seen in previous, in other, twin projects that there are preference studies planned which are very important because they aim at collecting a couple's view, so parents' view, all about the genetic newborn screening or diagnostics flow chart and so on. So including psychological, social, ethical issues, and also privacy. We have a task to select genes, to select disease. This is crucial. This is very crucial, not only probably from the Screen4Care, but generally, because again, DNA sequencing is a method, basically. I don't want to simplify, but definitely is a technique. We can use panels, we can use whole exome sequencing, we can use whole genome sequencing, and in the future do not know universal sequencing. But the point is that we need to know what looking for, which diseases, which genes, prioritizing those diseases according to a robust and experimental-based, evidence-based pipeline. So this is what we are doing for in this work package, and then based on that, we are very close to our final, design based on a large discussion with many other, initiatives, including, BabySeq, and also we use orphanage sites, so many. And we pilot our infants. We have different approaches. We may have more than one pilot, at least 18,000. We hope to be able to run more than these infants, thanks to new partners that may be interested in jumping on board in the Screen4Care. That's very important, as Nicolas said. We will use whole genome sequencing with our aim to provide an early genetic diagnosis in early symptomatic infants, resulted negative at the newborn screening, but followed up for 2 years within the project. So this is very important. Nobody will be left behind. We will have a follow-up, and in case of symptomatic babies, we will do whole genome sequencing in order to run, of course, all rare disease, theoretically, genes to be studied. And then the other tasks are obvious, are evaluating the impact on NBS on families and also cost effectiveness for genetic newborn screening, because we have to run and we have to achieve results which must be sustainable in the interest of future health of our rare disease patients and families. Clinical studies are 5 preference studies. The designing of the panels, we have actionable panel, actionable diseases, treatable panel for treatable diseases, and also early symptomatic whole genome sequencing, as I have already described. I go on just to underline that we have a massive amount of ethical workflow, okay? Very engaging for all of us. So we have ethics for the preference studies, for application for the clinical trials, for the ACT panel, treatable diseases and whole genome sequencing. We are co-designing all the ethical applications across European countries because we have to be harmonized. We cannot do, spontaneous applications, very different each other. So that's important because our goal is to get approved and then to be able to run our newborn screening pilot. And then we are preparing lots of telemedicine tools for interviewing couples in various steps during the pregnancy. And of course, the consent will be also digital, and also the delivery will be done through telegenetics. Finally, the workflow, I have 1 minute still. Sorry. I'm trying to stay in my time. The co-design, of course, again, you heard this word very, very, very many times. So co-design, co-creating, that's important because we are different entities. We are academics, we are companies, we are patients association. So co-design and cost-effective this newborn screening pipeline, and at the end, we agreed that the best way to have a cost-effectiveness, homogeneous way to screen infants is to have one hub only, where all samples will be screened, run, and sequenced, irrespectively to whole genome and to gene panels. We have a patient's reports divided in our research report and a diagnostic grade report. And then, of course, many partners providing new pipelines to identify copy number variations because we have to be exhaustive. All mutation types must be identified by our genetic newborn screening. And then partners, developing these pipelines, and the repository, which is the Screen4Care platform, where all data will be collected and present. Finally, impact. We know already we have impact at birth because we are running newborn screening, so it must be sustainable, and it may also have interesting IP issues as new diagnostic tools and novel strategies, and of course all the ethics fully addressed. But also early onset symptoms will be cared of because we will have early symptom whole genome sequencing studies, and generally rare disease phenotype cycling will be met using the digital tools as the symptom checker. But of course, we hope as a research project to have impacts in many other areas as research, health system, society, perceptions about newborn screening, about the importance of genetic diagnosis, and obviously patients and families, which are the core, they are co-actor inside the Screen4Care. Thank you for your listening. Of course, these are our partnership. As Nicola mentioned it before, we have companies inside, as you see, all of them. We are a PPP in terms of working together. And if you like, just go on our website and check Screen4Care. And we will hope that in 1 year time, we will have much more results to be shared. Thank you very much.